I am Dr. Ankit Bansal, Consultant Pulmonology and Critical Care at Fortis, Jaipur. Today I welcome you all in the webinar by Chest Council of India on pulmonary hypertension. We have two all-rounders today for our academic feast. Dr. Parvez Kaul is Professor and Head Department of Pulmonology and Chief of Clinical Research, Sher-e-Kashmir Institute of Medical Sciences, Srinagar. He is a well-acclaimed pulmonologist with State Task Force Chair RNTCP and Chairman OR RNTCP. He has more than 500 presentations and more than 340 journals and book chapter under his name. He has been awarded by many prestigious awards which include OASMA Oration Award, Pfizer Human Initiative Award, Bill and Melinda Gates Award. He is part of National Technical Advisory Group related to immunization, Government of India, and hold key positions in various prestigious societies related to field of pulmonology, including Editor Lung India. Our second speaker, Dr. Atri Gangopadhyay, needs no introduction. He is our esteemed pulmonologist from Medica Hospital, Ranchi. He strongly believes in effective communication for global unification. His disease of interest lies in air pollution, tuberculosis, and pulmonary hypertension. Dr. Parvez will be talking about chronic thromboembolic pulmonary hypertension, commonly known as CTEPH, and Dr. Atri will be discussing intricacies in management of pulmonary hypertension in various clinical scenarios. So, friends, I invite our first speaker, Dr. Parvez. Over to you, sir.
Good evening, and thanks to the Chest Council of India, and I welcome you all for this webinar on pulmonary hypertension. And I have to give my thanks to Dr. Krishna and his whole team at the Chest Council and all the members of the Chest Council of India for having organized this webinar on pulmonary hypertension, which is something that I have very close to my heart. And I've been tasked to talk on chronic thromboembolic pulmonary hypertension, or the CTEPH. First, we know that there has been an updation of the hemodynamic definition of pulmonary hypertension, and that happened in the 6th World Symposium on Pulmonary Hypertension that happened in Nice, France in 2018. And the mean pulmonary arterial pressure, which was recognized as 25 millimeters of mercury, has been reduced down to 20 millimeters of mercury. And in addition, pulmonary vascular resistance, pulmonary capillary wedge pressures have been incorporated into the definition. So if you have an isolated precapillary hypertension, you have to have a mean pulmonary artery pressure determined by right heart catheterization of more than 20, accompanied by a pulmonary capillary wedge pressure of less than 15 and a pulmonary vascular resistance of more than 3 units volts. And if there is a combined pre and post capillary hypertension, it's got to have more than 15 millimeters of the pulmonary capillary wedge pressure and more than 3 Wood units of the pulmonary vascular resistance. Whereas in isolated post capillary hypertension, you have more than 15 millimeters of pulmonary capillary wedge pressure and less than 3 Wood units of the pulmonary vascular resistance. And this is the updated clinical classification of pulmonary hypertension, and there have been some changes that have been brought about by the Nice symposium, especially in the group 1 hypertension, where we have pulmonary hypertension which has a long-term response to calcium channel blockers, and then a pulmonary hypertension with overt features of venous or capillaries, that is the PVOD or PCH involvement. However, what I have been tasked to talk about is about the chronic thromboembolic pulmonary hypertension. So what is it? It's basically pulmonary hypertension resulting from a single or a recurrent pulmonary emboli, and they are a result of incomplete resolution of the emboli, which obstructs or narrows the large pulmonary arteries. And in addition, there is a progressive distal vasculopathy that develops over time. It's a rare complication of acute or recurrent pulmonary embolism, and it's characterized by, as I said, fibrothrombotic obstructions of large vessels, that's the large pulmonary arteries, combined with small vessel vasculopathy. And if not treated, it has a very poor prognosis. And if we talk of survivals at 5 years, if the mean pulmonary artery pressure is more than 40 millimeters of mercury, your 5-year survival is around 30%. If the MPAP is around more than 50 millimeters of mercury, your 5-year survival drops down to only 10%. And fortunately, we have a number of treatment options that we are going to discuss during the course of this presentation. So when do we diagnose CTEPH? There got to be two things in combination. One is pulmonary hypertension, defined and diagnosed accurately by various methods, and then evidence of persistent perfusion defects despite anticoagulation, and that is persistent perfusion defects that are defined and documented by various imaging modalities that we're going to discuss further. So how common is it? Consider the United States of America. We see about 300 to 600,000 cases of acute pulmonary embolism in the USA per year, and nearly 60,000 to 100,000 deaths as a result of pulmonary embolism. And about 1% rate of unresolved or persistent PE occurs. And so if we look at that, that translates into 2,400 to about 5,000 cases of CTEPH per year. So it's more common than what is recognized. And there are a number of risk factors, and this Bonderman study was conducted in 2009 with about 433 patients. And in this study, compared to pulmonary arterial hypertension, features like presence of splenectomy, infected pacemaker, ventricular atrial shunts were associated with a high risk, high odds of developing CTEPH compared to those when you did not have these risk factors. A history of malignancy or thyroid replacement therapy was also associated with, and along with recurrent VTE was also associated with a high risk for CTEPH. And in acute pulmonary embolism, if there was a large perfusion defect, there was a recurrent pulmonary embolism, or there was an idiopathic PE that was associated with a greater risk of development of CTEPH. And there is certain hemostatic factors like elevated factor 8 or more Willebrand factor, and there was elevated fibrinogen variants, and in certain cases, some fibrinogen variants that are resistant to fibrinolysis. Then non-O blood group and elevated lipoprotein A levels were associated with a higher risk of CTEPH. Then associated factors, as I talked about, were splenectomy, VA shunts, and infected pacemakers. Then patients with inflammatory disorders like osteomyelitis, inflammatory bowel disease, antiphospholipid antibody syndrome, and those who had a serum level of higher number of inflammatory markers like CRPs, interleukins 2, 4, 8, and 10 levels, and then, of course, hypothyroidism. So essentially, the pathogenesis is that you have an acute pulmonary embolism, which is incompletely resolved and gets organized and forms a kind of a organized thrombus, which gets adhered to the vessel wall. And then there's a lack of thrombus angiogenesis and development of fibrotic stenosis and occlusions. And then there's a adapt to vascular remodeling of resistance vessels, which are distal, and this is all compounded by in situ thrombosis and presence of infection, inflammation, immunity, and certain genetic factors which are not very well defined. If you look at the famous PENGO study that came in the NEJM in 2004, the cumulative incidence of CTEPH after a first episode of pulmonary embolism without prior deep venous thrombosis was about 3.8% at around 2 years. And how do we diagnose them? The clinical presentation is pretty much the same as you have in any form of pulmonary hypertension, which is primarily evidenced by shortness of breath and presence of right heart failure or right heart dysfunctional symptoms and clinical features. However, at times we may be lucky to find a clinical pointer in auscultation of the peripheral lung fields, which may be a bruit that is caused by turbulent flow in partially occluded proximal pulmonary artery. In up to 30% of cases, it may be seen, and though it has a low sensitivity, but it has a very, very high specificity and is incidentally not seen in idiopathic pulmonary hypertension. So what is the prognosis? The 5-year survival is around 30% if mean pulmonary artery pressure is more than 40, and only 10% in mean pulmonary artery pressure is more than 50 millimeters. If we look at pulmonary thromboembolism, the 5-year survival of pulmonary thromboembolism is more than 90%. So CTEPH, if and when it ensues, it confers a very adverse prognosis to pulmonary embolism. And however, if we treat it and treat it surgically, then the fibrous survival may actually go up to 90%. So this is a disease which is there, which has a poor prognosis, but if treated and operated well in time, may actually have a good prognosis as well. So how do we diagnose it? Two things need to be assessed. We need to know that there is pulmonary hypertension, and then we have to detect and quantify the degree of vascular occlusion. And how do we get to know about the pulmonary hypertension? That is, echocardiography is a routine, good screening tool for detecting pulmonary hypertension. And then to quantify and to exactly know the various patterns of the pH, we have to do a right heart catheterization, and then we have to image the vascular system in order to find out where exactly is the occlusion and how to quantify the degree of vascular occlusion. And as it is said earlier, the diagnostic criteria include that you have a mean PAP of more than 20, pulmonary arterial wedge pressure of less than 15 millimeters of mercury, elevated pulmonary vascular resistance, and evidence of chronic pulmonary embolism on CT or a VQ scan. So VQ scan is often very commonly used, and of the two, this was a study, a retrospective study. They did of 27 patients, 142 males, and the gold standard was case records of the pulmonary hypertension service. 78 patients of CTEPH were there, and 61 were confirmed by pulmonary digital subtraction angiography. And the sensitivity of this and the specificity of the VQ scan was over 95%, and whereas CT had a sensitivity of 51%. And specificity of 99%. This is what a ventilation perfusion scan looks like. And if you look at it, the upper one is the anterior and the posterior scans. And you can see perfusion defects that are ventilated well, that is suggestive of a perfusion defect. And many a times, the SPECT is combined with the VQ scan that gives a colored picture and a better depiction of the perfusion defects. As you can see here in this, that you have perfusion defect very nicely seen. And on CT, we can see a variety of things, and that is, you can see a fresh thrombus, which can actually normally gets reabsorbed, and that can have a recanalization, web subband, stenosis, retraction with partial or total obstruction. And this is a CT where you can see on the left, there's an acute CT. It is acute because there is evidence of plump arteries. And on the right side, we have, on the left of the screen, you have the chronic vessels, chronic embolic occlusion of the vessels. Again, you can have a clot in the vessel. If it forms an acute angle with the vessel wall, it's an acute. And if it forms an obtuse angle with the vessel wall, it's chronic. You can have a layered clot, which can be seen in various projections. Or at times you may see a web-like structure, and that can be seen not only on the CT, but also on angiography. And once we come to angiography, it is regarded as a gold standard by many, and you can generally, you require to have more than 2 views. And in this case, you can see that in one view, the occlusion is not that well seen, whereas the one which shows an arrow shows the abrupt cutoff, because this is a different projection of the CT. You may see narrowing, you may see cutoffs or stenosis. Then pouch-like defects can be seen in occasionally, and here there is a band on the right side with a post-stenotic dilatation. Next, we come to the management of these patients, and after we have secured an accurate diagnosis, they need to be on lifelong anticoagulation, and we need to assess them for operability for pulmonary endarterectomy. So you have a CTEPH diagnosis, we have to assess it by an expert team, and they look at whether it is operable or non-operable. If it is operable, they go for pulmonary endarterectomy, which is the treatment of choice. However, if it is not operable, then we have to target medical therapy with or without balloon pulmonary angioplasty, and many a times we have a failure of either of these therapies, and we have to reconsider them for either the surgical or the medical options. Pulmonary endarterectomy is a potential cure, which is the treatment of choice for pulmonary CTEPH. And unfortunately, the trouble is that many patients are either inoperable or have a recurrent or persistent pulmonary hypertension after the endarterectomy. So we need to understand what is the operability, and that is when we need to find out whether there is a chronic thromboembolic disease that matches the pulmonary hypertension. That means you got to find out if there is a difference in the hemodynamic to the radiographic appearances if there is a mismatch. And we also have to know what is the pulmonary vascular resistance. We also need to understand as to whether the surgical expertise for this procedure is available at the place or not. And we also have to assess the comorbidities that confer an adverse prognosis to the patient. And pulmonary vascular resistance is very important. For example, in this patient, you can see that the proximal pulmonary vessels seem to be okay, and there is a distal pruning. There are some defects which are peripherally present. So this would not be a great case for pulmonary endarterectomy. And contrast this with this case where there is an abrupt cutoff that you can see of the left side and one of the right pulmonary arteries. You can see that this is a patient where probably the patient can be helped by surgery. And pulmonary vascular resistance reduction is the key. If the post-operative pulmonary vascular resistance is more than 500, your mortality is as high as 10%. Whereas if the post-operative pulmonary vascular resistance is less than 500, your mortality is about 9.9% only. And your basic functional status determined by a DLCO, or 6-minute walk distance, and then the pulmonary resistance, total pulmonary resistance. They actually give you an idea as to what will be the prediction of mortality after pulmonary arterial endarterectomy. We also have to understand that this is not an embolectomy, this is an endarterectomy and needs a median sternotomy, a cardiopulmonary bypass, a deep hypothermia for preserving the cerebral perfusion and for preserving the brain. We will need circulatory arrest at times in order to prevent the operative field by getting bloodied by backflow through the bronchial vessels. This is what we need to do, that you need to remove the clot, you need to remove the endothelium and strip it away from the vessels as distally as we can. And this is the surgery result. You can see the narrowed blood vessels becoming enlarged after the thromboendarterectomy. Alternative option to patients who are having pulmonary hypertension as a CTEPH is the balloon pulmonary angioplasty. And this is no longer considered a desperate or experimental modality. It's fast evolving. And though it's a high-risk procedure, it is reserved for experienced centers. This is a depiction of the balloon angioplasty. You can see that the blood flow is certainly much better once you have done the pulmonary angioplasty. Medical therapy has been tried with iloprost, sildenafil, and bosentan, has unfortunately not been very useful. However, then Riociguat came and the 2 CHEST trials, where it's a stimulator of soluble gonadotropin cyclase, and it resulted in improvement of the 6-minute walk distance and a secondary improvement of the pulmonary vascular resistance, cardiac output, pro-BNP and functional class. However, there was no effect on clinical worsening. So this was found to be useful, and it actually is recommended for use in patients with CTEPH. This is a cartoon that depicts the change from the baseline in 6-minute walk distance. And as you can see, at 16 weeks, there was a distinct difference between the placebo and the Riociguat. Macitentan has actually come very recently in the MERIT trial. It came in Lancet Respiratory Medicine 2017, and it demonstrated a reduction in the pulmonary vascular resistance as well as improvement in the 6-minute walk distance at 24 weeks. So there is, whenever we have a patient with CTEPH, the management has got to be multidisciplinary, involving a number of teams, be it the pulmonary vascular surgery, CTEPH, interventional radiology, and nuclear medicine, including the intensivists as well. So concluding, ladies and gentlemen, CTEPH should be considered in all patients with pulmonary hypertension, as this is probably the only cause of pulmonary hypertension that is potentially curable. A VQ scan is a first screening tool for diagnosing CTEPH. We have already outlined the diagnostic criteria based on the mean pulmonary arterial pressure, the wedge pressures, and the pulmonary vascular resistance, with evidence of chronic pulmonary embolism on imaging modalities, be it the CT, MRI, or the VQ scan. Cardiomedical management involves the PAH targeted therapy and oral anticoagulation. The surgical treatment of choice is CTEPH, in CTEPH patients is pulmonary endarterectomy. And balloon pulmonary angioplasty and stenting are being recognized increasingly as alternate modes of therapy. Thank you for your kind attention.
Very good evening, ladies and gentlemen. On this August evening, when we are discussing pulmonary hypertension, and after Dr. Parvez Kaul finished his fantastic lecture, I am feeling so nervous like I can't tell my feelings in front of you. Anyways, I will try my best. I am talking about intricacies in management of pH in various clinical scenarios that we see day to day. See, we all will share this thing that pH can cause despair. It is definitely fatal. It worsens the prognosis of a pre-existing disease and it increases the disability. But when we are pulmonologists dealing with challenging cases, it is our role to take our patients and their attendants from despair to hope. And this is what, after this lecture, we are all going to do from tomorrow. We all know that the pH can be in the following groups 1, 2, 3, 4, 5. And I will speak about the various clinical scenarios that develop into or are complicated by pH. A common presentation encountered by all of us: a known sick patient, established chronic diagnosis, multiple comorbidities, develops recent onset dyspnea on exertion, dry cough, hypoxia on exercise, occasional hemoptysis, and we rule out infection, fluid overload, thromboembolism, infarction, heart failure, effusion. Then suspect to diagnose early. A very high index of suspicion is needed to catch pH early. Don't neglect an unexplained dyspnea or other symptom for which treatment is ineffective and common investigations may be normal. If a person is dyspneic, better safe than sorry. Many patients who had functional dyspnea or who were regarded as functional dyspnea turned out to be something serious later. So, pH may be rare, but it is also underdiagnosed or diagnosed late. You will always get a lead time in survival and quality of life with early diagnosis. Please note, if you don't get obvious clinical findings except hypoxemia and it turns out to be pH, you are early. If you get features of right heart failure, you are late. And if you get features of peripheral thromboembolism, please search for the thoracovascular surgeon. Common diseases which develop into pulmonary hypertension. Group 2, which are diseases of the left heart. This is our fold. Group 3, COPD, ILD, post-TB sequelae, bronchiectasis, sleep apnea. Other diseases: common obesity, metabolic syndrome, connective tissue disease with or without pulmonary involvement, chronic viral hepatitis leading to chronic liver disease, treated lymphohematogenous malignancies, diagnosed hemoglobinopathies surviving till adulthood, established hemolytic coagulopathies, drug-induced pH. Other scenarios which are uncommon: an old CVA, musculoskeletal disorders of chest wall and other sites, endocrine disorders affecting the skeleton, CKD, long survivors on hemodialysis, cancer survivors, prior history of multiple chemo, radiation, immunotherapy. But if we play by their rules, we lose. If we create our own rules, we have a chance. And why I am saying this? Because first, do no harm. Why? Because any international guideline strongly recommends right heart catheterization for diagnosis of PH, which may not be widely available, definitely risky intervention, and propensity for causing harm. And as per our various international guidelines, we know this, that by right heart catheterization, when the mean pulmonary artery pressure exceeds a certain limit, we call it PH. But if we don't want to do any harm and RHC is not readily available, so we have echocardiography. And in good operator, transthoracic echo is very good. If inconclusive, you can also consider transesophageal. But the eyes see only what the mind knows. So please speak to the person performing echo. Say that you are suspecting pulmonary hypertension, because echo everywhere. Which echo do I trust? In my city, there are so many echo centers, and once I remember a gentleman patient had 3 echoes on the same day, 3 different doctors, 3 different reports. So please speak to the person performing echo that you are suspecting pulmonary hypertension. And what do we ask in an echo? Order a Doppler echo, RV systolic function, LV eccentricity index, estimated PASP by a TR jet, TR jet velocity, RARV dimension. These are the certain things we need to ask. And this slide, we can go through it later, and I will share the slides, don't worry. The probability of pH in echo is measured over here, and this has been validated so many times that you can consider this a gold. And certain poor prognostic markers on an echo for pH. This is irrespective of PAH, mean other than group 1 also, any pH, these poor prognostic markers stand true. Now, why does pH develop in other disease? Why would a CKD, CLD, lymphoma, leukemia go on to develop pH? Because everything boils down to 2 things: hypoxia, recurrent micropulmonary embolism. These 2 things accumulate, ultimately causing pH. And we all know this thing. We had to memorize this in our second MBBS, final MBBS, even during our MD DNBs, that what imbalance causes pulmonary hypertension. But everything rests upon chronic hypoxia, recurrent micropulmonary embolism. Now, so we established a diagnosis of pH in an established chronic patient via a echo. How do I manage now? Please remember, if something can be cured by surgery, please go for early surgery. So we also need to know in our city who is the cardiac surgeon, who is the thoracic surgeon, who is the vascular surgeon, because it is something very vast that although the course may be same, but people specialize differently. So in wherever we practice, we need to know someone who are one of these 3 who can manage the surgically manageable cases. Because any day I will tell you that surgeon is almost equivalent to God, that surgery can cause miracles, especially structural cardiac diseases, CTEPH especially. Also, sometimes in the lung, if there are localized lesion, a surgery can do wonders. Scenario-based management. Let's come one by one. Common scenarios. Drug-induced pH. If you look in the our literature, or if you look in the internet, you will see a huge list of drugs. But the most common drugs encountered in Indian practice are most important: drug abuse, methamphetamine, cocaine, amphetamine. Certain drugs for weight loss: aminorex, fenfluramine. Hematological malignancy: dasatinib. Other anti-cancer drugs: bleo, busulfan, interferon alpha, IL-2, etc. So, general principles applicable to all our patients ending up in pH, which may not be a PAH. Stop the offending agent if identified. It is the easiest thing. Just like hypersensitivity pneumonitis, if you can identify something, stop it, and things can become better. Rule out chronic thromboembolism, anticoagulation, as Dr. Parvez again and again emphasized in his previous lecture. Please rule out. Correct hypoxia, pulmonary rehabilitation. Look for correctable biochemistry, metabolic parameters. Now, this is what we see day in, day out. I am sure all of us over here, pulmonologists, see 2 to 5 group 3 PH patients every day. They may not be diagnosed. Do you know why? Because there are pre-existing respiratory complaints, worsening symptoms despite optimum medication, worsening dyspnea, dry cough, occasional hemoptysis. Now, these complaints can be attributed to any pulmonary disease, but if you are confident with your management, that you have given very good medication to this COPD patient. Then why did this COPD patient deteriorate? It may be a group 3 pH. You have given excellent medication to the sleep apnea patient. Why did this patient deteriorate? It may be group 3 pH. And that occasional hemoptysis is often the clue. Again, hemoptysis can be there in any pulmonary disease, especially chronic disease, but here it is very, very important. Desaturation on exertion. Someone who was a stable pulmonary patient should not desaturate on exertion. That always indicates something new, and one of the suspects is pH. Clinical features. Look for overt signs of right heart failure. Again, I would want to tell all of you, if you get right heart failure, you are late. If you get hypoxia without right heart failure, you are early. Demonstrate the hypoxia. Look for features of peripheral thromboembolism or venous insufficiency, and look for signs of disease suggestive of groups 1, 2, 3, 5. Remember, every dyspnea may not be a pulmonary patient. So every PH patient may not be a pulmonary patient. Special points in management of group 3 PH. Immunization. I advise just 2 immunization. One is the pneumococcal vaccine, once to be repeated after 5 years. One is the influenza vaccine annually. This just after the end of the monsoon. Oxygen therapy. I am a big fan of oxygen therapy, and I have seen oxygen therapy working wonders. And if you can convince a person about a concentrator, then it can definitely be cheap in the long run. Chest physiotherapy, pulmonary rehabilitation, pharmacotherapy. What drugs? Please remember that extra bronchodilation always helps. There is no dyspnea that cannot be slightly relieved by bronchodilation. Every dyspnea will benefit by bronchodilation. So if you are prescribing a long-acting bronchodilator to any chronic patient of dyspnea, you are not doing wrong. You are actually helping the patient. Diuretics for relieving right heart wherever there is a fluid overload. Diuretics are wonderful thing. pH specific therapy. This is something very, very dubious, but I extensively searched on the internet and I have got some evidence for you regarding pH specific therapy. But which pH specific therapy are not recommended? Endothelin receptor antagonist, prostacyclin prostaglandin analogs, riociguat, calcium channel blockers are not recommended. So which drug is left? Phosphodiesterase 5 inhibitors, sildenafil, tadalafil, vardanafil. They have a possible role. See, there have been trials, there have been retrials. Some trials recommend, some trials do not recommend. But when I went through, I found these two landmark published literature, one in 2008, British Journal of Clinical Pharmacology. This was in COPD. One was in 2014, pulmonary hypertension and right heart dysfunction in chronic lung disease. And both these guidelines suggested that there was evidence to suggest that these drugs have a role in moderate to severe pH in a patient of chronic lung disease. So based on these two literature, you can definitely try these phosphodiesterase inhibitors in a pH with a chronic lung disease. And there is some benefit. It does not cause harm, more important. But please don't combine with other phosphodiesterase inhibitors or IOC-GUAT. We should watch for postural hypotension, and other adverse effects are not notable. I have experience of sildenafil and tadalafil. Tadalafil has once daily dosing, sildenafil has thrice daily dosing. So that is upon you. And what is pulmonary rehabilitation? This is a graded exercise program with without ambulation. Nutrition advice, take care of antioxidants, micronutrients, essential amino acids, adequate but not excess calories. Physical and vocational rehabilitation. If you can get a job for this person, and with the right team, it always works wonders in chronic lung disease patients. I am very lucky where I work. I have a wonderful physiotherapist. I have a wonderful dietitian person, and we are doing pulmonary rehabilitation, and it is helping some of our patients. Hemoglobinopathy, sickle cell disease. Hydroxyurea works wonderfully. There is a weak recommendation of endothelin receptor antagonist or prostacyclin agonist, and there is a strong contraindication for phosphodiesterase inhibitor because of propensity of causing harm. Let's come to the other scenarios where we see pH other than group 3 disease. Chronic liver disease. You may be surprised, but I found many chronic liver disease where after ruling out everything, we did an echo and we found this moderate to severe pH. Prevent overhydration status. Look for embolism. PDE5 inhibitor has been tried, but very limited evidence. I would not want to advocate it here. Improvement of nutrition. Oxygen and NIV helps. Which NIV? CPAP preferable to BiPAP. Connective tissue disorders. Here remember the pH is more due to the vasculitis leading to recurrent thromboembolism component. So optimum immune suppression to suppress the vasculitis. This is something acute. So give liberal oxygen, encourage ambulation. Very careful with respect to anticoagulation because whenever there is vasculitis, there is a risk of pulmonary renal hemorrhage. So very careful with respect to anticoagulation. You may actually lose the patient. Malignancy. This is something which has a very bad prognosis. And any person with malignancy landing academic awards or some is almost always due to microembolism, which may be tumor embolism and palliative care, and this does not have a very good prognosis. And in such cases, you would be justified to tell the attendants the bad news early that this is something very bad. Metabolic endocrine disorders. What was funny when I talked to my endocrine colleagues or ortho colleagues, what I found that ultimately due to the endocrine or metabolic disturbance, there is arrhythmia and tachycardia, and there is a chronic load on the heart, and it actually behaves like group 2 pH. But I am not the cardiologist, and I have too much respect for the cardiologist. Working on the beating heart is very difficult, so I would never comment on group 2 pH. Such cases I always refer to my cardiologist friends. Chronic kidney disease. These patients are generally overhydrated and diuretics don't work because there is anuria. So diuretics don't work. So ultimately we need to go for optimum fluid balance by hemodialysis. Bronchodilation and non-invasive ventilation has some role. No role of pH specific drugs. I myself had tried tadalafil on some patient with consent, but I did not find much benefit. So after few days I had to discontinue it. Ultimately, you need to look towards the hemodialysis overhydration. But yes, that SOS bronchodilation helps these people. Transplantation. See, whenever we are talking of pH, ultimately there is a loan of transplantation. But whenever it is an established chronic disease, these are generally contraindications to transplant surgery. Option for consulting with a transplant program should be offered at the time of diagnosis. The moment you diagnose pH in any patient, you should tell them that ultimately you may need to talk with a transplant guy. But very limited experience in India to formulate some statement or policy. And unfortunately, most patients get excluded from surgery due to various reasons like irreversible liver disease, irreversible kidney disease. Often these are contraindication towards organ transplant. So transplantation still now very limited role. So everything said at length, what do I actually do? I must tell the patient attendant about this new development that I'm very sorry, you had a chronic disease and there a new chronic complication developed, which is not curable, which has only limited treatment options. I would want to stress on the detailed nutritional and exercise advice, and I would want to stress on the role of oxygen and NI. And what dilemma I face? Often I am asked by the patient attendant, why did this new development occur? I have to tell them that because your pre-existing disease was very severe and unfortunately didn't work out for you. Another very difficult question, will I die earlier? Here I boldly tell them, you will improve with the advice I am giving you, except unless it's a malignancy. Then I don't say this. In all other patients, I stress that you will improve with the advice I am giving you. Next question, will I be totally bed bound? No. If you follow the nutritional and exercise advice, you will not be totally bed bound. Another question, will I need to take oxygen? I strongly stress, yes, this will keep you healthier. You do need to take oxygen. So, certain take-home messages. Look for hypoxia and embolism in established chronic diseases. No hypoxia is trivial and must be investigated for PH if other causes ruled out. Any PH diagnosed prior to clinical features of heart failure has a better prognosis. No magic pills yet, but some therapy always better than no therapy. The CTVS surgeon should be a very good friend. And when you get cases at a specialist or super specialist level, the rare complications become common possibilities because the common complications are diagnosed at primary care level. So, with these words, I end my deliberation. And as per current scenario and as per PH, we shall all brave the storm. The session is now open. I request our moderator, Dr. Ankit, to take over. Thank you.
So, extremely useful, precise, informative presentations by our both our speakers. So I would like take this opportunity to congratulate both our speakers for their academic treat. So I would be having both our speakers with us. So I welcome Dr. Parvez and Dr. Atri for after their wonderful presentations. So my first question would be to Dr. Parvez, as this is about the present COVID scenario. So what is your opinion? That is, you will see a lots and lots of CTPH patient post-COVID scenario.
It's actually there used to be that that TV advertisement. I don't know. All of you are very young. There used to be a Crown TV. I don't know when you heard of that or not. It will say that time will tell the difference. So over a period of time, then they said that time has told the difference. So time is going to tell about COVID because even if we are around 6 months into this disease, it's practically very early days for us in this understanding. Yes, given the fact that we have evidences of thrombogenicity in them, we have an elevated D-dimers in them, procoagulant state, some autopsy studies having shown that there were evidences of diffuse thrombosis in the lungs and other organs as well. Yes, it seems that we may be in for, and then we don't routinely employ thrombolysis or something where you could possibly reduce the thrombus load. Yes, I mean, it is fair to actually believe that you might be actually ending up with a lot of CTEPH. Only thing is that, as I said, for county TV, time will tell the difference. It's only a matter of time when we'll know whether actually they do transform into a CTEPH or not.
Okay. So again, similar thing is from one of our audience, Dr. Shankar. That is, you are encountering pulmonary embolism in present your COVID patients.
Yes, there are pulmonary emboli. In fact, interestingly, that many of the people who actually looked at the pathophysiology and the radiological imaging of COVID first went on to believe that we are dealing with a regular viral pneumonia. And over a period of time, they felt that the ARDS that they develop is not behaving the same way as you would see in a regular patient of pneumonia with the acute respiratory distress syndrome. And they tended to believe it's more akin to something that we see in high altitude pulmonary edema. And then they found in one of the autopsy series that was seen in Italy that there were lots of patients who had diffuse embolization, thrombosis in the pulmonary vessels. And we also have seen pulmonary emboli, especially in younger patients. Fortunately for us, our critical patient numbers is low, and the numbers who actually expire is even lower. So
Okay.
yes, we have seen it, but fortunately, it is not a very big number.
Okay. So Dr. Atri, as you know that tuberculosis is a very important disease in our country. So there is one question from Dr. Narayan. Is post-tuberculosis sequel with pulmonary hypertension? Any guidelines related to it?
Up till now, there are no guidelines formulated for pH in post-tuberculosis. One of the reason for the same may be, even till the last decade, all the pulmonary guidelines were dominated by people from the West. ERS, Gold, GINA, CHEST, ACCP. Only in this decade, recently, have our Indian researchers really woken up that the same disease in India may be totally different from what it is in the West. And now we are in the process of formulating our data going towards this guideline. So, not yet, but maybe very soon, because post TB sequelae is still something unknown or unheard of in the West. It is something very, very common with us.
Okay. Again, there is a question for you. So, what is an approach of for pH in smoker with HIV?
Uh, Very good question. Whoever formulated, I would salute that person. So, smoking, if there is a established lung disease, even delayed smoking cessation will help. Number
Hmm.
one. So, my first advice to this gentleman or lady would be that please give up smoking. Please enroll into a dedicated smoking cessation program.
Hmm.
After that, the HIV is notorious to be associated with pH, but with the advent of highly active antiretroviral therapy, the HIV survivors and they also have a very good quality of life. So, if this patient can very well be managed by, let's say, pulmonary rehabilitation, optimized oxygen delivery, care of the right heart, and actually pH specific drugs may not be warranted in such patients.
Okay. So, Dr. Parvez, there is a question for you. How you will de-escalate vasodilator therapy in PH?
In regular pH or CTEPH?
In regular PH.
Okay, I mean, we have to always classify pH whenever we are dealing with it. And there is a definite difference in the way of managing a regular pulmonary arterial hypertension compared to other subgroups of pulmonary hypertension that we have based on the recent WHO symposium that happened in Nice, France in 2018, 18, and then those were published in the ERS and the JCC journals. So we actually may require to use the combination generally used for pulmonary arterial hypertension is one of the endocrine receptor antagonists, or we generally use bosentan and ambrisentan, and combine it with sildenafil or tadalafil. This is the most commonly used combination, and eventually we use it in terms of following them up. We follow them up with regular measurements of their functional ability, their requirement of, and then also do their subsequent echocardiography and find out how they are doing. And patients who are doing well over a period of time, we may be able to say after 6 weeks, find out how they're doing, and they every 3 months find give them a recheck and find out if they're symptomatically better, then you may be able to de-escalate. Otherwise, you have to continue. And
Continue.
yes, you need to continue it for a long time. Yes.
Okay. Dr. Atri, uh, is there any classification? This is asked by one of our audience, Dr. Ashutosh. Is there any classification in which we can differentiate pH into mild, moderate, or severe? Is any
Uh,
kind of marcation or a differentiation?
there are 2 points. One is using the echo findings, and another is the WHO functional class, with the functional class 1, 2, 3, 4, where 4 is something overt cardiac failure. And why is this important? Because what has been published literature as well as my own experience, that if you can give optimal vasodilator therapy in the form of endothelin receptor antagonist and a phosphodiesterase 5 inhibitor combination, then if someone is in functional class 2 and 3, there can actually be a reversal of class at 3 months or 6 months down the line in terms of improvement in the PASP and improvement in the 6-minute walk distance and the desaturation. So this is the thing which we clinicians commonly follow.
Okay. Um, as you know, the in stage 3 is what we encounter as a pulmonologist most frequently. So the question from the audience is also pertaining to stage 3. Dr. Baljot Singh is asking that what is the pH drug therapy benefit in group 3? So Dr. Atri, you will answer this.
Yeah. Initially, at the end of the 20th century or in the first decade of the 21st century, there was a nihilistic approach that there are no drugs. You can only give oxygen, you can only consider pulmonary rehab and think of transplantation. But slowly, as the experience with phosphodiesterase 5 inhibitors grew, there have been trials, there have been papers published in accredited journals where there has been seen that sildenafil and even tadalafil has some benefit in these patients. It slows the disease progress. But the other classes of drugs like the ERAs or the prostacyclin analogs, up till now, there have been no evidence for the same. But yes, now we have weak evidence for use of sildenafil, tadalafil. If the patient tolerates, you can continue it and the patient will definitely be happier than before.
May
Okay.
I add a
Yes, sir,
point?
please.
Yeah, what Dr. Athri said is absolutely right. Only thing that I want to add a word of caution. Our hemodynamic definition of pulmonary hypertension has actually come, has made a change recently. I mean, from a cutoff of 25, we have come down to 20.
20.
And in the subgroup of patients who have 20 to 20, 21 to 25, we do not have a lot of data. And these are the subgroup of patients who actually should be enrolled into registries and clinical trials. And over a period of time, as Dr. Atrish suggested, we will have robust data to suggest whether targeted pulmonary artery hypertension drugs are very useful in them or not. As of now, we have a very weak, as Dr. Atri said, very weak evidence for phosphodiesterase 5 inhibitors, but nonetheless, we don't have much of evidence for other drugs, especially in light of the fact that your hemodynamic definition of pulmonary hypertension has come down by around 5 millimeters of mercury. So for that subgroup, we have no data. And that's why it's very important that they need to be put into clinical trials and follow up over a period of time. Because as of now, as Dr. Atri said, oxygen on one side and transplantation on the other side are probably the only modes of definite therapy that we have known till now.
Dr. Vijay, question is mainly pertaining to that only. Is there any difference in the management of IPF and the other ILDs? So I think we got the answer in the same way, that we have to give oxygen or the lung transplantation is the choice in that particular regard. So there is one question from Dr. Paresh. Dr. Atri, what should be the oxygenation goal for PAH with COPD?
Very tricky question because hypoxia causes pH and overcorrection may cause CO2 retention. Wonderful dilemma which we all face.
Yes.
As per my experience, what I practice, 88 to 93% SpO2 and preferably a ABG every month in these patients to see the CO2 level. We consider normal CO2 less than 45, but in these patients, even up till 60, we can go safely, 6060. That every monthly ABG with a PCO2 less than 6060 and target saturation 88 to 93%. But I would also want Dr. Ankit's view, Dr. Parvez's view, with your experience.
Yes.
For a COPD patient, I would agree with you that anything beyond 88 SpO2 would be something that we would want to aim at. And talking of the PCO2, I agree with you that we should look at their PCO2, be more permissive about the cutoffs, and try to maintain a saturation of around 90%, around plus points 2. And that should be the goal for most of our patients.
I totally agree with you, both of you, because again, these are the very tricky cases that we frequently encountered, and we have to make way out of it. So definitely, I agree with you. COVID era. This is a COVID era. From last 3 months is a COVID era. So many questions related to it, many queries related to it. So Dr. Atri, uh, again, how would you treat PE or pulmonary hypertension in COVID-19 patient? Our friends Nagaraja and many are asking these questions. What would be the treatment lineup for those
Fair
patients
enough.
with COVID
Fair
and
enough.
pulmonary embolism?
Any patient who is a chronic pulmonary patient encounters COVID is a very potentially very sick patient.
Hmm.
So the management of COVID in this patient should be similar to what we are practicing for severe COVID as per the guidelines we are getting from ICMR
Hmm.
currently.
Hmm.
The management of pH should not change in these patients. But
Hmm.
one point which I would want to add here, that those who are surviving COVID, let's say some gentleman, lady developed severe COVID, and
Hmm.
with our team's hard work, we managed to save that person. Such a person should be under a pulmonologist surveillance, maybe every 3 months to 6 months for the next 2 to 5 years to see whether they are developing pH in future or not. That is more important than the management of the current pH patient developing COVID.
Hmm. Okay. So,
So,
uh,
sorry,
Dr.
go
Parvez, you
ahead.
want to add something?
Yeah, I just want to add a bit that the cumulative incidence of pulmonary embolism in COVID patients is as high as 24% in certain series, and
Hmm.
especially those who have a COVID-related pneumonia. So I agree that, as I said earlier, that time is going to tell as to whether they are going to eventually develop CTEPH or not. Because if you look at the natural history of pulmonary embolism, around 96 to 99% of them do resolve spontaneously. There might be some residual pulmonary thrombi, which may not be associated with pulmonary hypertension, which would be a chronic thromboembolic disease without a pulmonary hypertension. So, as Dr. Atri said, yes, we have to manage them exactly the way you would manage them without a pulmonary, without a COVID as well. However, you have to keep in mind that this is a hypercoagulable state where there seems to be a high level of D-dimer even at asymptomatic stage at times. So you have to follow them up for development of pulmonary hypertension in the long term.
Okay. So there is one scenario which is asked by Dr. Vijay. How would you manage pH in COVID ARDS patient with hypotension if you have RV dysfunction and with normal systemic dynamics? That is, suppose so that is the patient is ARDS patient with RV dysfunction with hypotension. How we will manage the pH in those sort of patients?
The current scenario, as mentioned,
Hmm.
my first focus would be to preservation of life of this patient,
Hmm.
which would involve, which may actually involve a intubation ventilation to
Hmm.
maintain the ventilation of the lung, maintain our oxygenation levels.
Hmm.
The blood pressure in such patient has to be managed by cardiogenic ionotropes, vasopressor,
Hmm.
and the pH management over here has to be at the second line. First here should be preservation of life, take care of that acute phase before I would dream of adding anything pH specific in this patient.
Absolutely.
So a very important aspect, Dr. Parvez, as Dr. Atri has rightly said that 2D echo is a very important screening tool for pulmonary hypertension. So this question is from Dr. N.H. Krishna. So do all pulmonologists should be trained for 2D echo himself while treating PH?
I tell you, I mean, if you look at the Western scenario, I mean, pulmonary hypertension is basically managed either by a pulmonologist or a cardiologist. So either of them can actually be trained to do an echo, a 2D echo, and get an evaluation of the pulmonary hypertension. And not only that, I'm personally aware of pulmonologists who not only do the echoes, do right heart cath as well, and to get an accurate assessment of the pulmonary dynamics. So yes, I would agree with you that anybody who is interested in taking PH as a special interest in pulmonology must be trained in 2D echoes and should take it up as it's a very routine procedure. And if you can do an ultrasound for other things, you can very easily do an echo as well.
Yes. Um,
Ultrasound and
Dr.
echo.
Khatri, your views on it?
Yeah, ultrasound and echo are now very readily available in India. Even towns without major facilities have ultrasound and echo. So I strongly believe that the post-graduation training program in pulmonary medicine mandatorily should involve a training in that lung ultrasound and echo. It must be mandatorily incorporated.
Okay. So, again, a question for Dr. Parvez. It is by Dr. Praveen. In which kind of pH would you recommend anticoagulation?
So anticoagulation is primarily required for patients who have a CTEPH, and anybody who has a pulmonary hypertension on top of a prothrombotic state or a thrombosis, evidenced or not evidenced, you should anticoagulate them for life. So that is one. And there is some suggestion that in patients with pulmonary arterial hypertension, the group 1 hypertension, anticoagulation might help as well. However, there is sketchy measly evidence for that. Nonetheless, for patients with CTEPH, there is a definite evidence, and you got to anticoagulate them for life. What anticoagulation you give, you can. There's a lot of evidence for vitamin K antagonists, but however, there is a building evidence for novel anticoagulants, and over a period of time, they might take over.
Uh, as we are aware, there is low, intermediate, or high risk pH. So, where you place which category where? Category 1, 2, 3, 4, 5, in which in which of the categories of low, intermediate, or high risk pH out of these all available 5 categories?
Anything
Doctor
which has
Doc, Ji Doctor 3.
anything which has a multifactorial etiology or an unclear etiology means what we commonly consider group 1 dash or group 5 has to be a high risk pH. Group 3 pH, what I have seen that the progression is definitely slow and till a very long time the patient is stable. So that would be for me a low to intermediate risk pH. Cardiac, I don't have too much experience. So, and any cardiac thing, I liberally refer it to my cardiology friend. So no comments on that. CTEPH Parvez sir is the boss.
So, Dr. Parvez, you consider CTEPH as a high risk category
Yes, I
of
mean,
the.
if you look at a patient with CTEPH and look at his 5-year mortality, it's quite high. I mean, in absence of treatment, it's quite high. However, if you treat them, then your results are beautiful. Only challenge is that the kind of surgery that you require for them is not easily available everywhere, and the surgical expertise has got to be there. And now we have alternate therapies like balloon pulmonary angioplasty. Again, they are the ones that have a requirement for a high degree of expertise. So yes, it's a high risk category in the sense that your mortality is very high, especially if your pulmonary vascular resistance is high, and it is directly dependent on the pulmonary vascular resistance, as also dependent on your functional class, defined by whether your DLCO is too low or your 6-minute walk distance is too low. So if your functional class is poor, your pulmonary vascular resistance is high, these are the kind of people who do not do well. And if you can intervene, and that is if they're operable and you do a surgery, or they are inoperable and resort to other therapies, which could be a balloon pulmonary angioplasty, or in certain cases targeted medical therapy, they might do better. But without that, it would be a high risk category.
Okay. Dr. Atri, there is one question from the audience. Where you place right heart catheterization, which is considered as a gold standard for diagnosis in your clinical practice? In what sort of patient you will look for this entity?
If something comes out to be a, let's say, primary PAH or a group 1, then mandatorily such a patient must get a right heart catheterization. But if we can identify some incriminant disease, if we can identify that this pH is because of this pre-existing disease, then there for RHC we must consider the benefit harm ratio. But if no cause is evident, to label someone as group 1, RHC must be mandatory.
Okay.
And also in patients who are undergoing transplantation, that would be one group that who must have mandatory right heart cath. I mean, a patient who has a primary lung disease and has to go for transplantation, we must do a right heart cath as well.
Okay. So, Dr. Parvez, where you place Riociguat in the management of CTPH?
There are certain trials available for it, and the chest trial, chest 1, chest 2 trials depicted that there was a definite evidence of an improvement in the 6-minute walk in distance at 24 weeks, and there was an increase in the cardiac output, a reduction in the anti-proBNP, though there was not a very great difference in terms of clinical symptomatology. But there is a suggestion, yes, Riociguat may be an alternative to surgical therapy should a person be inoperable or he develops a persistent hypertension after pulmonary endarterectomy, which by far is the mode of therapy for patients with CTEPH. So anybody who is either inoperable or has a persistent hypertension, after you have operated upon him, he may be considered for Riociguat therapy.
Okay. So, I would be needing comments of both of you. There is one question where you place as a role of pulmonologist in treating pulmonary hypertension. I know it is a cake of a cardiologist also treat pulmonary hypertension, physician, pulmonologist. So, what is your take on this? And Dr. Parvez first.
So as I said that I borrow my comment from my experience in the West, and we have seen that there are very many pulmonologists who are interested in pulmonary hypertension, and they take it as their area of interest and go full throttle on doing pulmonary hypertension. So they are trained in doing echoes. They're trained in doing right heart caths. So, and they have lots of patients who are on continuous infusion of prostacyclins. So I've seen that. So given that background, I think that kind of a model can be very easily replicated in India. If you are interested as a pulmonologist in following this up, and I know that there are very astute clinicians and pulmonologists in the country who are doing pulmonary hypertension as their specialty, especially in Bangalore. Dr. Murali is so much interested in pulmonary hypertension and CTEPH. Yes, I would agree that there is a distinct role for a pulmonologist in taking up pulmonary hypertension as his interest. Only that he has got to be interested in it. Otherwise, you keep on referring them either to the transplant surgeon or to the cardiologist.
Dr. Atri, your take on this?
Yeah. In the current Indian patient to specialist doctor ratio, every specialist doctor after a certain point in his career has a choice of seeing or not seeing certain group of patients. Right from our training days, any disease which is presumed to be rare and which does not have a good prognosis can fall in our choice that I choose not to see this disease, which I myself felt during my training days and when I started doing my practice as a specialist. And I developed a soft corner for this pulmonary hypertension. Once I started seeing patients, once I started understanding them, I found that it was not so rare as underdiagnosed. And once I started offering them some dedicated treatment, I found out that the prognosis was also not so poor as may be in published literature. So the pulmonologist definitely has a role in PH, and a pulmonologist can create a good amount of experience for PH in his sphere of influence. Why not?
Definitely, I think we should explore and be treating more of pH frequently in our clinical day-to-day clinical practice. So, Dr. Atri, one more question to you: that do you assess sleep disorders in the evaluation of pH in every patient, or what is your take on it?
Mandatorily, yes. Whenever a person I am suspecting PH comes to me, I tell them about the common treatable, correctable causes, and sleep disorder is one of them. So, mandatorily, yes, I do a proper sleep testing in these patients, and I would recommend others also.
Okay, so sleep is an important entity that has to be looked forward while evaluating pulmonary hypertension. That is an important part. So another workup is that in the Dr. Parvez, we have three different categories of medications which are available for us to be used in PH. Where you place these medication categories in the treatment of lung disorders, like endothelial receptor antagonist or the other category of nitric oxide synthetase. So, where you place all these three part in our treatment part of the category 3 patients?
If you talk of lung disorders, as I said, that pulmonary hypertension as a result of lung disease, and we have certain diseases wherein we have proved benefit of some of these agents. But generally, as I said earlier, also there has been a change in the hemodynamics definition of pulmonary hypertension. We have gotten down the cutoff from 25 to 20, and this is an area which is uncharted. And if I say, as of now, endothelin receptors or prostacyclins or others do not have a very great data in their favor, and as Dr. Athre earlier said, there is sketchy data, I would at best say, in favor of phosphodiesterase inhibitors. So I would ask for evidence to be built over a period of time and then probably answer your question, because we're not sure as of now whether they're useful at all, because there is not much data in their favor in this group.
I
Okay.
would want to add 2 points.
Yes.
Prostacyclin analog, definitely no. They are very tricky. Earlier ERAs, there was a lot of gray area, but once I found out this macitentan, in group 1 I became a huge fan of macitentan because I actually saw what is the reversal of class. So in my group 3 PH patient, as the safety of macitentan is established, if someone requests something extra out of the box, then with their consent, I would want to try macitentan.
Okay.
Maybe it can generate some evidence in later, which may be for, which may be against also.
Okay. Okay. Dr. Atri, what about you told about the lung transplantation, particularly in the category 3 patient? So, is pH any hindrance for lung transplantation, severe pH?
Unfortunately, yes. The aim for lung transplantation in a group 3 PH is for the primary disease of the lung. And once this person develops into PH, then that person's tolerance for the transplant procedure and the follow-up may be severely hampered and harassed. So such person, ILDs, severe COPDs, post-TBs, if they should be referred for lung transplantation, then preferably prior to development of PH.
So it was a very important discussion taken from both Dr. Atri and Dr. Parvez. I would like to have your last comments on this. So, Dr. Parvez, your last comments on our webinar on pulmonary hypertension. Dr. Parvez. Dr. Dr. Atri.
Yeah,
Okay, meanwhile you can.
yeah. What I want to say is that, as I had repeated in my slide also, When a case comes to a specialist for a specialist consultation, sometimes entertaining the rare possibility may be common because the common possibilities must have been entertained and neutralized by the primary caregiver. So we need to suspect pH to catch pH. It is not rare, it is underdiagnosed. And if I catch it with right heart failure, then I am late. If I catch it with a demonstrable hypoxemia, then I am early and I have a chance with the patient.
Okay. Thank you, Dr. Atri. Um, with this, I would like to conclude the session. Pulmonary hypertension is an important entity where diagnosis is important and to be managed appropriately. So I would like to take this opportunity to thank our esteemed faculty, Dr. Parvez Kaul and Dr. Atri Gangopadhyay, to enlighten the House with their illustrious presentation. I would like to thank Chest Council of India, Dr. N.H. Krishna, Dr. Narayana, and our webinar coordinator, Dr. Vijay, to give us platform to disseminate information and education on pH. I would like to thank CIPLA for their technical support. Very important, all their attendees for their patient listening and their encouragement. Thank you. Thank you, Dr. Atri. Thank you, Dr. Parvez.
Thank you.
Thank you.